Hi, my name is Zinzi Bailey, and I'm a social epidemiologist at the University of Miami Miller School of Medicine. It is my honor to be presenting on this National Academies workshop on promoting health equity in cancer care. As a social epidemiologist focused on operationalizing structural racism in relationship to lung cancer disparities, my talk today will be focused on distinguishing social determinants of health from social determinants of health inequities, focusing on structural racism as a root cause of cancer care disparities. I'll focus on two main areas: unpacking racial and ethnic inequities in cancer, and highlighting the role of structural racism in driving racial and ethnic inequities. To begin, we must delve into the racial and ethnic inequities, and those particular to cancer, right? The United States has the dubious honor of being a world leader in health inequity. When we're looking at cancer, we can see that African American women are twice as likely as white women to be diagnosed with triple negative breast cancer, and much more likely than white women to die from breast cancer. The highest rates of kidney and liver cancer are among Native Americans. And, the NCI identifies biological factors, healthcare access, socioeconomic factors, chemical and physical exposures, diet, physical inactivity as key risk factors associated with disparities. However, there tends to be very little discussion about what is truly driving those risk factors, what I would call root causes. If we look below the surface of cancer outcomes and proximal risk factors, we will find the root causes of social determinants of health and health inequities. We find an interaction of isms, racism, classism, sexism, and imperialism that ground the distribution of social determinants of health across different groups and thereby drive the contributing risk factors. Put in another way, we can put it into this kind of graphical representation. We can see that the measures of health and health inequities are at the far right. That's what we think about with, when we're talking about these downstream risk factors, incidence, and mortality. But these risk factors and measures are driven by key living conditions, including the physical, social, work, and service environments in which people are born, grow, live, work, and age. We often call these the social determinants of health. The real question is, why are we seeing the patterns of living conditions that are systematically worse for some versus others? Those living conditions, those social determinants of health, are driven by institutional inequities in both public-private sectors, as well as the very laws and regulations we have in the books. That is, in turn, driven by social inequities, including racism, sexism, classism, heterosexism, those isms that we just talked about. A focus on solely social determinants of health can be agnostic to how those social determinants came to be distributed in the population in the ways that they have. We will do tons of work focused on driving physical conditions or social environments without sustainably addressing inequities, because we're not addressing those root causes, the social determinants of health inequities. This will put us at a disadvantage when trying to eliminate racial and ethnic inequities in health, or as we are discussing here, cancer care. More specifically, we cannot begin to talk about racial and ethnic disparities in quality and access to care without talking about structural racism, because it is at the root of these inequities and drives the distribution of related social determinants of health. Furthermore, the elimination of health inequities depends on the degree to which we invest in dismantling structural racism. What exactly is structural racism? In order to delve into structural racism, we have to understand what racism is. Racism, as opposed to a lot of people are thinking, oh, it's a particular act. It's a particular action. It is not a collection of these kinds of isolated events or isolated acts that are bundled together. Racism is a organized social system in which the dominant racial group, based on a Ideology of inferiority categorizes and ranks people into social groups that we call races and uses its power to devalue, disempower, and differentially allocate valued societal resources and opportunities to groups defined as inferior. There are multiple levels of racism that have been conceptualized, including internalized, interpersonal, and institutional racism. However, I'm particularly concerned and focused on structural racism. Structural racism can be defined as the totality of ways in which societies foster racial and ethnic discrimination through mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources reflected in history, culture, and interconnected institutions. This is very much a comprehensive system and process of discrimination rather than isolated or even clustered events. In this simple graphic, we can see that structural racism drives other forms of racism and create pathways to health inequities, including through inequities in social determinants of health. These pathways include economic injustice and social deprivation, environmental and occupational exposures, inadequate healthcare, state violence, political exclusion, etc. As we're thinking about these pathways, I think it's important for us to walk through a relatively simple example that we're likely familiar with so that we can demonstrate some of this in practice. Racial and ethnic residential segregation in the United States is a key dimension of structural racism that seemingly operated within the housing sector, but it propped up and facilitated other institutions and sectors in their discriminatory policies, whether they be colorblind or color explicit. In the United States, the Homeowners Loan Corporation created an inventory of all residential areas in the United States to assist banks in making loans by literally color coding the denial or limitation of financing or refinancing to certain neighborhoods based on their racial and ethnic composition. This is often referred to as redlining. Green areas were the best, lacking a single foreigner or Negro, while red areas had been infiltrated by Black residents or other undesirable populations, and therefore were ineligible for federal housing administration backing. And redlining wasn't just a clustering of people. This practice concentrated investment in white suburbs, simultaneously segregating people and hastening the decay of the inner city. Redlining operated alongside and complementary to restrictive covenants, enforceable agreements on how land could be used, for example, restricted to white residents, disparate impacts of zoning, land use policies, and discrimination in historical and current rental and mortgage markets. Further, it set the stage for colorblind distribution of resources over time through environmental hazards, inadequate healthcare, inadequate education, state-sanctioned violence, and municipal disinvestment. It's not just the actual movement of people and segregating of people that we're talking about. We're also talking about the segregating of resources and systems, institutions. Through the structural racism of segregation, redlining and benign neglect are teamed with restrictive covenants, zoning, and neoliberal market forces, as well as the discriminatory act of the Social Security Act of 1935, unfair school funding, and concentrated policing over the life course, over generations, and across domains to produce differentials in wealth, education, income, exposure to concentrated poverty, intergenerational exposure to low quality hospitals, schools, and jobs. Again, put it in a different way and different graphic, we can also demonstrate these mutually interacting mechanisms more broadly. This image developed by Anusha Vable, based on my 2017 Lancet paper, seeks to depict graphically the mutually reinforcing inequitable systems operating within a society steeped in structural racism. By following some of these arrows, we can highlight the pathways by which in this country, for example, you can suffer from a felony for the rest of your life. Structurally racist policy, like those supporting hyper-incarceration and hyper-policing, has impact on the lives and deaths of individuals and communities. First, a felony conviction impacts the type of job you can get. In this country, we tie our healthcare to our jobs, so the felony conviction will impact ability to access healthcare and the quality of healthcare that you receive. Employment also impacts how much money you will make, your ability to pay bills, which will in turn impact your credit. And your credit impacts where you can rent and if you're able to buy a house. In this country, we tie the funding of our public school system to property taxes. So where you live can really impact the quality of education your children receive, right? So that in that way, the criminal legal system has intergenerational impacts on your family, your children. And the criminal justice system also impacts your ability to access the social safety net. And not depicted in this graph, but especially important during our current polarized society, a felony conviction can also affect your ability to vote. These interactions work together to impact our health in a variety of ways. What we must keep in mind and remember are these key components of structural racism. That structural racism is involves mutually reinforcing inequitable systems, operating in different sectors or domains, and at different levels, which serve to reinforce discriminatory beliefs and thereby normalize and legitimize the historical, cultural, institutional, and chronic adverse outcomes for people of color. Structural racism is not just the result of private prejudices, so we cannot just be focused on changing individual attitudes. It is produced and reproduced by laws, rules, practices embedded in our economic system, in our culture, in the very way that we provide healthcare, how it is reimbursed. So we have to chart a course towards transforming our policies and institutions that help maintain the US racial hierarchy. In order to achieve health equity, we must consider the historical and multidimensional nature of structural racism in order to have lasting change in our communities. With that, I thank you.